Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today we'll be discussing something that a lot of folks and their loved ones struggle with, and that's high blood pressure. We'll explore what high blood pressure is, why it's important to diagnose, and some of the contemporary approaches to treating it. My guest is my friend and colleague, Dr. Joseph Diamond. Dr. Diamond is the Director of Nuclear Cardiology at the Long Island Jewish Medical Center and is a designated American Heart Association clinical specialist in hypertension. He is also an Associate Professor of Cardiology at the Donald and Barbara Zucker School of Medicine, and I am delighted to have him on our show. Joe, welcome to Well Said.
Thank you very much, Ira.
So to get us started, let's start by just explaining to our listeners what high blood pressure is. And I said that you had a certification in treating hypertension. Are hypertension and high blood pressure the same thing?
Well, in many circumstances, they can be considered the same thing, with some slight differences in terms of how you use it. So, for example, first of all, defining blood pressure, period. Blood pressure, I would say, is really the pressure of the blood as it's pushing up against the walls of the arteries. And as you know, it's usually presented to individuals as two numbers, a top number, which is called systolic blood pressure, and a bottom number, which is called diastolic blood pressure. And these both have importance. The systolic blood pressure is usually is the blood pressure that occurs when the heart, the main pumping chamber of the heart, the left ventricle, is contracting. And so that's going to be a higher number. And the bottom number, which we call the diastolic blood pressure, is the blood pressing against the walls of the arteries when the main pumping chamber of the heart is relaxing. Now, according to our current American Heart Association, American College of Cardiology, and other guidelines, we've defined normal blood pressure as being less than 120/80. High blood pressure is higher than that. And when it's sustained, a chronic condition, we usually refer to that as the clinical condition of hypertension. So, you know, your blood pressure changes throughout the course of the day, response to normal activities. Having blood pressures that are consistently above normal would result in the clinical diagnosis of hypertension.
Okay, there's a lot there to pick apart. Thank you for getting us started so clearly. So you mentioned that there's a difference between having a kind of an isolated measurement where the blood pressure is high and making a diagnosis, a clinical diagnosis of chronic high blood pressure or hypertension. So how many high blood pressure readings do you need before your doctor says, oh, you have high blood pressure?
I'm not going to give you a quote, absolute number of readings, but what I would say is this. Sometimes blood pressure may go up during the course of the day to support a particular activity that you're doing that may require you to have higher blood pressure, such as if you're exercising. This would be an appropriate response to a particular stress. It's kind of like what we would call the flight or fight response. Whereas if you're like under a stressful situation, you may need a faster heart rate, you may need a higher blood pressure to support that activity. But the problem that can occur is when people start to have these high blood pressures without a stressful event, with nothing occurring that is needed to have a higher blood pressure to support it. And so when blood pressure is consistently above 120/80 and there's no particular stressful event that needs it to be higher than that, we would call that clinical hypertension, and we call it that because it can be associated with some risks that go along with this, quote, chronic elevation of blood pressure.
Yeah, we'll get to the consequences of high blood pressure in a minute, but I just want to pause here for a moment and talk about how we actually measure blood pressure. So, I mean, I suspect most of our listeners are familiar with going to the doctor, having a cuff put on their arm, stethoscope put in the crook of the elbow. The clinician is listening while they're pumping up the cuff. What are they actually doing there, and how does that lead to a measurement of what the blood pressure is?
Having high blood pressure is generally silent. There are no symptoms with it. So really the only way to know if you have high blood pressure is to measure it. And so as you mentioned, the most common way that it's done is to put a cuff, a blood pressure cuff around the arm and to inflate the cuff and listen with a stethoscope. And there are now a lot of automated machines that can do that, so individuals can actually measure their own blood pressure at home if they have concern, or it could be done in pharmacies, or it could be done in the local office. But generally what's happening is a cuff is put around the arm, it inflates to actually cut off the circulation in the arm a little bit, and then as the cuff releases, the circulation begins to return back to the arm. That very first returning of circulation would be the systolic blood pressure, and then you would continue to listen, and when those blood pressure sounds disappear, that actually reflects the diastolic blood pressure.
So the doctor or the nurse is listening for that first whoosh whoosh that signifies the blood's getting past the cuff, and then the sounds disappear, and it's back to kind of the low end of the reading. Is that right?
That's exactly right. And of course, electronic devices don't hear anything. They use a different measurement technique, which is often based on assessing something that we don't clinically talk about, which is mean arterial pressure. But they're actually they're pretty accurate in giving good blood pressure readings as well.
Now, you mentioned that people can take their blood pressure at home, as opposed to waiting until they're in the doctor's office or at a pharmacy or something like that. Is it important for folks to take their blood pressure at home?
Well, it's not really something that we all have to do all the time, but it certainly is a very useful thing to be able to do, just to know if blood pressure is a problem. I think for individuals who may have risk factors for hypertension, a family history of hypertension, it might be something to do. And, you know, I can tell you in my own practice, it's become certainly more of an important tool this past year during our pandemic, where, you know, people were not coming into the office, and we're doing a lot more assessments at home. This self-monitoring has become certainly much more prevalent.
And isn't it also the case that some people have a different blood pressure at home than they have when they're sitting in a doctor's office?
Yes, you're absolutely right. And, you know, there have been a lot of studies on this, and it's really, really very interesting. If you take blood pressures by having a physician take the reading in the office, or have an ancillary care person or a nurse take the blood pressure reading, or do home blood pressures, and you compare all those different approaches to what we call the gold standard of blood pressure measurement, which is 24-hour ambulatory blood pressure monitoring, I think many of your listeners would be surprised to know that the most accurate assessment is actually the self-measurement of blood pressure, and not really the readings that are obtained in the physician's office or by the physician. And it's not because your physician is bad at taking blood pressure. It's because a lot of us have a very typical reaction of being in the office, what we call the white coat effect, which doesn't necessarily mean that you're nervous when you're having your reading taken or that you're reacting to a white coat. It's really what happens when your arm is feeling a cuff squeeze for the first time, and it's in an environment that you're not familiar with, and so it's accurate to get self measurements of blood pressure.
So even if somebody's not feeling anxious in the doctor's office, their body may be reacting in such a way that it elevates their blood pressure more than it would be if they were doing it at home. Is that what you're saying?
Yeah, absolutely. And, many people will still have the same reaction even at home. So what I'll often tell individuals is if you're going to check your blood pressure at home, just don't take one reading and record that one. Take maybe 3 to 5 readings and either use the last reading or maybe average them. And that's going to be an accurate reflection of where blood pressure is. And it will take into account that white coat effect.
And how big a difference are we talking about here between somebody taking their blood pressure at home under relaxed circumstances and being in your office or my office? How much difference does it really make?
Yeah, it makes a big difference. We're talking about maybe upwards of 20 millimeters of mercury, the units we use for blood pressure, which is a big difference. And I'll tell you another thing that does come into play here, and that is the measuring blood pressure the right way. That is so important, and there are actually guidelines now from the American Heart Association on the correct technique for measuring blood pressure. I think most of us don't know that if you're taking blood pressure, you should be sitting in a chair with a backrest. Your feet should be flat on the ground. So if you're in the doctor's office and you're getting your blood pressure checked on an exam table with your feet dangling, that's going to give you totally useless readings. Blood pressure should be done in a silent, quiet environment. A person who's getting the blood pressure check shouldn't be talking and shouldn't even be actively listening. The person, if they smoke, which we hope not, should not have smoked within about 30 minutes of getting the reading. And blood pressure should be checked with an empty bladder. If you have a full bladder, that's going to affect the reading as well. So there's a lot to do to make sure the measurements are done correctly. And of course, the equipment should be good too. It should be, if it's an automated device, it should have been calibrated at some point to know it's working correctly, and the blood pressure cuff should be the right size cuff. So not everybody will fit a standard arm cuff. Many people might need a large arm cuff. And if the cuff is not the right size, the readings will be off by quite a bit.
So if you take those proper precautions, and we're talking about accurately determining blood pressure the right way, which I can tell already is kind of two big ifs. How prevalent is high blood pressure or hypertension? How many people really have an elevated blood pressure?
Right, and of course we know that high blood pressure is very common. First of all, when we look at prevalence, we check for two kinds of prevalence with regard to high blood pressure. We look for the prevalence of overall hypertension, and we also look for what's the prevalence of hypertension that's been controlled properly on medication. And that kind of tells us how we're doing in terms of treating this very common condition. And a lot of us who do hypertension work, we rely on data from the National Health and Nutrition Examination Survey. It's a big government-sponsored research survey that goes through periods of decades to examine what the prevalence of hypertension is. And the last time this big survey was done, between the years 2015 and 16, the prevalence of hypertension was about 29%. Keeping in mind that the prevalence of hypertension increases with age, so that over the age of 60, the prevalence is closer to 60%.
60%?
Yeah, so it's very common. The prevalence of hypertension also, we see it as being more prevalent in non-Hispanic blacks than in non-Hispanic whites. And, of course, the prevalence of hypertension has gone up as our definition of hypertension has become more strict in the most recent years. So when we used to say,
so let me ask you, let me ask you a question about that. So I think a skeptic listening to you, you're saying that more than half the people over 60 have high blood pressure, might rightfully ask, well, maybe your definition of what's high is wrong, as opposed to labeling all of these people with a disease. Could you explain that?
Yeah. So, in 2017, guidelines for hypertension changed, and the definition of high blood pressure went from 140 to 120 millimeters of mercury over a span of a few years. And so as a result of that, the prevalence of hypertension goes up. But it's really important because it's based on outcomes data. In other words, if you have a high blood pressure, meaning blood pressure is above 120, what is the risk that you may have a stroke or a heart attack? And so we're seeing now that those risks go up as early as with blood pressures being higher than 120. So that if you have blood pressures between 120 and 130 for the systolic blood pressure, you may have higher risk of stroke than if your blood pressure is between 110 and 120. And so that's what drives these numbers with respect to prevalence. Now, on a positive note, I could tell you that the prevalence of controlled hypertension is better than for just blood pressure alone. And those numbers have been improving between 1999 and about 2010. However, we've had a kind of a stalling of that. The actual prevalence of controlled blood pressure seems to be flattening out over the last few years. So I think we in the business of providing medical care need to do a better job in terms of, once we've identified high blood pressure, we have to do a better job in treating it.
So controlled hypertension, just to be clear, is that people have had high blood pressure in the past, but now it's in a more desirable range as a consequence of whatever treatment plan they're on with their doctor.
That's exactly correct.
Okay. You mentioned before that people don't know, there are no symptoms associated with having an elevated blood pressure, except perhaps in rare circumstances where it's really extraordinarily out of control. But for most people with elevated blood pressure, they don't feel anything. They're not aware of their blood pressure being elevated. But it does have serious health consequences nevertheless. And so could you just outline for our listeners what some of the downstream effects of having a chronically elevated blood pressure are?
Oh, absolutely. And unfortunately, it's numerous because this is a condition that affects the vasculature. So all the organs that are highly tied to the vasculature can be affected. So uncontrolled high blood pressure over long periods of time can lead to heart attack, can lead to stroke, can lead to the development of aneurysms in some of these arteries, such as the aorta, can lead to other problems of the heart, such as heart failure, can lead to thickening or narrowing or tearing of blood vessels in different parts of the body, for example, in the eyes, can lead to problems of the brain. We see more, not only stroke, but we see higher rates of dementia with high blood pressure. We see with people who have high blood pressure, it seems to be tied in with other metabolic syndromes, which means conditions of high cholesterol, diabetes also seem to be connected with high blood pressure as well. So again, all of these conditions are connected with chronic high blood pressure. So it really it behooves us to do our best to try to keep blood pressure under control as a really good primary prevention methodology.
So let's start talking a little bit about controlling elevated blood pressure. So first of all, let's talk about how low you need to get it. You said that anything over 120/80 is now considered elevated blood pressure. Does that mean everybody with a blood pressure higher than that should be on medication to lower it?
No, actually it doesn't. And really there's a lot of things that can be done prior to thinking about starting medication to try to help lower blood pressure, particularly, if it's borderline or mildly elevated. To summarize, I think some of the more important ones include exercising. Regular exercise is really, good for your overall well-being, but has a particular role in blood pressure control because as you exercise, you're kind of training your blood vessels to relax a little bit. And when the blood vessels relax, blood pressure goes down. Changing the diet is another important role that goes hand in hand with exercise. So, we know that diets that are high in fatty foods, that are high in salt, tend to promote high blood pressure. We know that diets that are very high in fresh fruits and vegetables, lean meats, whole grains, high in low-fat dairy, help promote to lower blood pressure. And one diet in particular that follows this pattern that people have probably heard about is called the DASH diet. DASH means Dietary Advances to Stop Hypertension. This diet has been shown to lower blood pressure even independent of just lowering salt or losing weight if you're overweight. So I think diet is important. And along the lines of weight, we know that if you're overweight, losing weight helps lower blood pressure. If your body mass index is above 25 kilograms per meter squared, which is the upper limit of normal, a measurement that takes into account your height and your weight, that as you lose weight closer to what's normal, blood pressure comes down quite a bit. We know that limiting salt really does help with blood pressure. I know there's been controversy over that area, but I think the overwhelming data suggests that lowering salt intake helps. Lowering stress. Now, that's not an easy one to do, but
No.
if you can lower stress levels, that will help lower blood pressure. And two other ones that I think are really important is that if you're smoking, you need to stop completely. It's just no bones about it. And if you consume alcohol, you really got to limit it. There's a very fine line with alcohol consumption. We know in cardiology that perhaps 1 to 2 drinks a day might have some benefit for the heart, may even help with issues like cholesterol and blood pressure, but more than that is bad, can really cause blood pressure to go up, can cause problems of the heart. So you have to limit your alcohol intake as well. So there's a whole bunch of lifestyle modifications that I think can be done before you entertain the idea of starting medication. If your blood pressure is high enough to warrant medication, we would recommend starting medication, but also including all those lifestyle modifications as well. In other words, medications do not free you from trying to improve the lifestyle.
Yeah, and actually that's exactly where I was going to go, that these things can be synergistic, right? So if you need medication to control your blood pressure, they're likely to be more effective if you're doing all of those positive lifestyle things that you were mentioning before.
Absolutely. Very, very important.
If we shift our focus for a moment to the need for medication for those people who have engaged in all of these positive lifestyle changes and still have a ways to go, there are dozens of medications that doctors can choose from to treat high blood pressure. Could you just run through some of the major sort of categories of drugs that might be prescribed and why doctors would choose one over another for a particular patient?
So the categories of medications that people are familiar with are usually the, quote, diuretics, which are the, quote, water pills. There are beta blockers. There are medications called angiotensin-converting enzyme inhibitors. People often refer them as ACE inhibitors, or angiotensin receptor blockers. People sometimes call them ARBs. There are calcium channel blockers, and the calcium channel blockers come in 2 varieties. There are medications called alpha blockers, and those come in 2 varieties as well. And then there are other medications not commonly used. They're called alpha-2 receptor agonists, and also direct blood vessel dilators or vasodilators. And so with all of these choices, usually what's done is, number one, looking for perhaps other medical conditions that might lead one to prefer one class of medication over another. So, for example, if you have high blood pressure but you're also diabetic, it's probably a good idea that one of the first medications is an ACE inhibitor or an ARB, because they have some protective effects for not only hypertension but for diabetes as well. On the other hand, for many individuals who just have high blood pressure without any other conditions, usually we would start with either a diuretic, the water pill, or calcium channel blocker, because those 2 in good clinical trial data have been shown to really decrease the risk of illness from heart attack and stroke or death. So those would be the first choices for people who don't have other medical conditions.
Now, blood pressure medications are often given in combination as well, meaning you take one from one class and one from another. Could you speak to why that's often done?
Yes, and I know for many people, they look at that curiously and say, well, why should I be on two medicines? I'd rather just be on one. But what we see is that a lot of combinations, for example, combining a calcium blocker with a diuretic, has a property that we call synergy. And what that means is that the two of them together have much more potent effects on lowering blood pressure at very low doses. And, in the old days, we used to say, well, let's try one medicine and just bring it up to the maximum dose. And then if that doesn't work, we'll add a second medicine. That was called the step approach. But what we see is that when you use that approach, eventually when you get to these high doses, there's going to be side effects. So the benefit of using two medicines that work well together is that you could get good blood pressure control with fewer side effects by using lower doses of those combination. So it's reached a point now that in these last few years, we're beginning to see these combination tablets that actually combine the two medicines into one tablet. So you only have to take one pill, but you're getting the benefit of the two medications.
And you mentioned side effects. Are there common side effects to multiple classes of drugs, or is it really totally separate for each of the ones that you kind of ran through there?
With most drugs, if you start prescribing them at high doses, you'll have an increased chance of having side effects. But most of the time, when you prescribe them at average or lower doses, most people tolerate them very well. Now, there are always going to be individuals who are sensitive to medication and may have problems. Most of the time, that might be with one or two classes of medication, but not necessarily, all the classes of medication. So sometimes there's a little trial and error in terms of picking the right regimen, but for most people, we can get a good regimen with really little, if any, side effects.
Are there some side effects that are just more frequent? I'm just imagining people listening may be curious about what side effects they might experience if they take one or more of these drugs.
Right. So, yes, there are some that are perhaps more common. So, for example, if you're taking a diuretic, which is a water pill, you're going to probably notice more frequent urination. And again, whether or not that becomes a problem depends on how bad that is. If it means 1 or 2 hours of urinating more during the course of the day, that's generally not a problem. But if it means, waking up every hour when you're trying to sleep at night, then, that can become a problem. Beta blockers are heart rate lowering medications as well as blood pressure lowering medications. So some people might notice fatigue, but often that's usually lasts a short time and then goes away as people acclimate to getting used to the drug. Some of the calcium blockers that we commonly use can cause some ankle swelling. Usually that's purely cosmetic and not a problem, but once in a while somebody might say it's really so swollen that it hurts and I'm having trouble walking. Then it can become a problem that would require intervention. So I think those are some of the more common ones.
And in general, how effective are these medications, either singly or in combination? In other words, how likely are you to be able to control somebody's blood pressure adequately with the lifestyle changes that you coach them to undertake and with medication to treat their blood pressure?
I think most of the time, for the majority of people, a combination of lifestyle modification with medical therapy really works well. I think there are few individuals where either A, they're very sensitive to medication and it becomes a problem, or B, the medications are just not working well. They have what we call resistance to medication or resistant hypertension, which by definition actually is hypertension that persists after being on 3 medications, one of them being a water pill. If your blood pressure stays high on that combination of therapy, we would consider that to be resistant hypertension. Once we see that, we have to start thinking, is there some underlying condition causing this hypertension, perhaps an endocrine problem or a kidney problem that we're not aware of, or a very common condition that we often don't check for, which is sleep apnea. So sometimes when we see resistance, we start to look for other causes of high blood pressure. If those turn out not to be the case, then we may have to either alter therapy or start to look for some other options.
And what other options are there for people? You've ruled out that there's some other medical condition like sleep apnea that's causing their high blood pressure. You've already got them on medications. They're doing the right thing in terms of diet, exercise, weight control, but their blood pressure still isn't where it needs to be.
If you had asked that question about 5 years ago, I probably would have to say not much. Right now, these days, actually, there are some new interventional approaches that we might consider for some individuals who are not tolerating the regimen or who are not responding to medication or who just, or who are very young and don't want to think about having to be on medication for, multiple decades of their lives. And so right now there are actually two interventional approaches that are beginning to gain some attention. One is called a transcatheter renal denervation procedure, and the other is called a baroreflex activation therapy. Those are some approaches that are being done in some countries. In the United States, they've been really under the investigational stages, although this year renal denervation has gotten approval from the FDA, so it's going to become a clinical tool within, I would say, the next few months. So renal denervation is what we call a minimally invasive procedure. In other words, it's not without risk, but it is not a surgical procedure. It uses catheters, these wires that get introduced into the blood vessels, usually from the groin area, just like with a cardiac catheterization for individuals who may have had that procedure. And these catheters are fed to the arteries that go to the kidneys. And a pulse of something called radio frequency is used to literally burn the nerves around those arteries that approach the kidney. Now, that doesn't mean the kidney lose all of its nerve supply, but this approach decreases the tone of the nervous system that tends to promote vasoconstriction. And so we see when this procedure is done that blood pressure goes down pretty much in everybody. Now, interestingly enough, this was done a few years ago in a trial that was called Simplicity. And when it was originally done, it didn't show any dramatic benefit compared to just doing a placebo approach, which means pretending to do the procedure but not really doing it. So there was a lot of concern about that, but it was found that there were probably some mistakes in these original trials, both how they chose their patients for doing this and also in some of the actual techniques with these catheters. So some of the newer studies, one of them is called Simplicity on and off meds. One of them is called Radiance. Some of these new trials have shown some significant benefits, so that's why the FDA has approved this technique and why we think it might be done. The other technique that I mentioned has not gotten as much attention. It's called baroreflex activation therapy. This is something like attuned to getting a pacemaker. A little device has to be put inside the body. And what this device does is it sends a little electrical signals to a part of the nervous system called the baroreceptors. By doing this stimulation, it seems to lower the tone of the nervous system that sends signals to the blood vessels to constrict. This is a little bit more involved because a device has to be put into the body, but it's really another kind of low-risk procedure. So that's another option for people who are not doing well with medications.
That's fascinating. Thanks for that update. So last question here is, where can our listeners go to learn more about high blood pressure and some of the other topics related to it that we've been discussing today?
If you do a search on the Internet, there are tons and tons of sites with information about high blood pressure. But, the Internet is not regulated, so not all of these sites have information that's been vetted to be accurate. So I can tell you, first of all, Northwell Health has a really nice educational site that was done by the Katz Institute for Women's Health. You can go to that site by just doing a search on Take Control of Your Blood Pressure, Northwell Health, and there's a lot of good information on that site. Other good vetted sites include the American Heart Association. The American Heart Association has a really excellent educational toolkits and information about hypertension, including a particular part called the National Hypertension Control Initiative, which is really something that has poured a lot of education, and there's a lot on their website from that. I'll also mention the American College of Cardiology, which has a nice summary of some very complicated guidelines, the most recent ones being the 2017 guidelines. There's a fairly nice summary of that on the American College of Cardiology website. So I think those are three good starting points for people.
That's great. Joe, thank you so much for being with us today and clarifying so many of these important issues related to high blood pressure.
Thank you, Ira. It's really been a pleasure. I really enjoyed speaking with you.
For more information about this program and to find past episodes, please visit sites.hofstra.edu/wellsaid. You can also subscribe to our free podcast available on Apple Podcasts, Stitcher, or wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.